Thank you very much. I have a couple of questions and a few comments. Obviously, it's very disturbing to see the trend move up from the charts you were seeing. A little promising that it kind of leveled off a little bit, but even concerned because of the American Indian, the females, that just seems to be skyrocketing.
That's right.
What do you attribute the slight decrease in? Is it a combination of, the mindset of people in the country, the state, maybe a few more parks? What is it? What would you say is the single most cause to have that stabilization? Is it the sodas that were removed out of the schools, or is there a combination of all? In your opinion, where is it?
Yeah, it always is hard to separate it out. We're looking at all the programs and policies. We're actually a partner in a $29 million NIH study that's going nationwide to look at which programs and policies are the most effective. And California, of course, will be a big part of that sample. But if you had to ask me now from the research that we're doing, and we just finished the report called, how to accelerate obesity prevention work in the United States with the Institute of Medicine. And they recommend, first and foremost, that the school is the hub. So prevention is key in the schools. So that means increased recess, improved food access, and decreased access to the foods that get in the way, all of the junk foods that kids eat, and especially the sweetened beverages. But also linking that with other efforts so that things begin to reinforce each other. So I think there is that there's so many things that Endowment and Kaiser are such leaders now in community programs, so we're going to see spotty improvements all across the state, which is exciting. But as the Institute of Medicine report concluded, if we don't deal with sugar-sweetened beverages, it's the elephant in the room everywhere, at the workplace, in government, in schools, in preschools. And of course, California has the best early beverage requirements now in childcare. So that was a great beginning to stop that taste for sugary beverages early. And then, of course, schools is great steps forward. So I think that when you see the dip at that particular moment over and over for every group, to me, that means that was the policy that changed the obesity rate in California. And all the other wonderful things that we're doing contributed all along, because we have things all along so that we're not higher than we should be higher than this based on the national average and with our numbers of Hispanic kids. So I think all the work that we're doing is keeping it down somewhat. And then this was a very abrupt change in soda consumption that we've been measuring. It's gone down with kids. So, and that creating that culture of health, there's an effect in the home, which we noticed afterwards when we were measuring. When you change things in institutions, the effect does filter down into the home. There's some, different value placed on that item because of what just happened. So I think that by setting policies that it is a form of education that really, really works, that people realize that you're doing it for a very important reason.
And I agree with you with regard to the education at schools and get the schools involved. Any thought, and you hadn't mentioned it at all, any thought about government or local government is to have some kind of statewide initiative to require every city to, in their planning of whether it's roads, parks, in their master plan, to look at healthy communities or some kind of healthy, I know the League of Cities and all the cities would say, Sacramento is telling us what to do, but when you think about trying to reduce overall healthcare costs, has that ever been part of the equation at all or not?
Oh, definitely. The local communities, that's what we're trying to do. We're going to be doing another study in California looking at the communities, which ones, given the same demographics, are doing the best and why. So we're just beginning that now. That's terribly important, and making it more competitive is a great idea. These are the best practices. This is what's working. The endowment has done a lot to support that kind of work, and Manal will be talking about how to bring forward those great best practices. So evaluate, and get that information out to people. They want to do the right thing. They want to know what works. Right. That's what we get called to talk about the most of anything, is tell us quickly, what works, because we have a certain amount of money and we want to make sure we spend it thoughtfully. So that's why these large national committees are beginning to take this on at the National Academy of Sciences.
Okay. I believe Senator Monning had a question or a comment.
Well, I want to thank Senator Hernandez and your staff for organizing this, because the data clearly show that this is it's been perhaps something you could call a silent epidemic that now is starting to get some sunshine on it, and this type of hearing certainly helps that. But I want to thank you for your work. I mean, the trends and percentages of pre-diabetic and diabetic in adolescence.
It's frightening.
Correct me if I'm wrong, but it used to be called adult onset diabetes.
Yes.
Because it didn't occur in children and adolescents. So
I know we were frightened when we saw 9%.
Right. You did reference several times the role of sugar-sweetened beverages, and I think you did comment that it represents the leading source of increased caloric intake among children and teenagers. Are there properties in sugar-sweetened beverages also that are more deleterious as a contributor to obesity, leading to diabetes, than sugar and other foods that?
Absolutely. As a nutritionist, I have said so many times in my career that a calorie is a calorie is a calorie. You know, all you have to do is reduce calories. You don't have to go on a special diet, just reduce what you're eating. Portion sizes is everything. And along comes this soda and sweetened beverage data. And we, as a profession, hung in there because we know about, you know, balance and calorie balance and energy. And the data just kept coming on, that kept coming forward, that given the number of calories, this was still an item, you know, one particular food item having this sugar, this package of sugar in a beverage. So we think part of it is related to the beverage, you know,
the liquid delivery.
The liquid delivery system, as they call it, yeah. Yeah. Part of it is that because it doesn't satiate one. So, you know, and there are other reasons as well, that, you know, that it's more dangerous. Like, you know, the corn syrup, fructose is metabolized in the liver, rather unlike, it's more like alcohol in some ways. So there's a lot of, you know, we could do a whole session on what we think the reasons are, but the data just keep coming out. The newest data this last week, you know, showing the cardiovascular risk factors, given that you control for everything else, drinking a soda a day is harmful for your cardiovascular risk. And the same thing with diabetes risk, that we now have to realize that it is in a unique category for a variety of reasons, and people are certainly trying to figure out exactly why that is. But I think a lot of it is satiety. There's
also a recent study that shows intake of sugar-sweetened beverages by children aged 2 to 5 is at about 30% of children drinking the equivalent of a can a day. Oh. Is it more deleterious to an infant in that age group than an adolescent? Yeah, and that's because it's a higher proportion of their caloric intake, and the higher the proportion, the worse, and the body isn't attuned to handling it very well either. So in childhood in general, it's a higher risk, and early childhood particularly so. Plus they're not getting the nutrients and the protective factors from food at all. So I think maybe calling it something different from a food might be helpful, so people do see it's a different item and should be used differently. But there was a figure from the Institute of Medicine, 20%, and this is conservative, 20% of all pounds in the United States over the last 35 years are directly related, directly caused by sugar-sweetened beverages. So, you know, it probably is higher than that, but they were conservative in their estimates. Well, thank you. And thank you for your work broadly in this area and for your colleagues. We appreciate it. Thank you.
Thank you. Any other questions or comments from any of the members? Seeing that, I'd like to thank you for taking the time to come out and make the presentation, and appreciate being here. I'm going to move on to item number 3, cost of obesity. First presenter is going to be Dr. Ron Chapman, Director of California Department of Public Health, and then we're going to have Pavljit Bindra, Doctor, Chief Medical Officer for Citrus Valley Health Partners. So we're going to start off with the first presentation. Good afternoon and welcome.
Good afternoon, Chair Hernandez and committee members. My name is Dr. Ron Chapman. I'm the State Health Officer and Director of the Department of Public Health. My first few slides actually focus on some of the data that Dr. Crawford shared, so I'm going to go through those very quickly. I'll skip them exactly, but I do want to highlight one stunning statistic, which is in 1985, about 8% of adults in California were obese, and in 2010, it was nearly 24%. I mean, we have seen a stunning change in just 25 years. Again, I'm going to just skip through these. You've heard it from Dr. Crawford. And now I'm going to talk about the cost of obesity in California. There is an enormous cost. Attributable medical costs were $15.2 billion annually, which is about 41.5% of public financing for healthcare. Lost productivity costs associated with overweight and obesity in California, $8.2 billion. And it's interesting to note that if adult BMI was reduced by only 5%, California could save $81.7 billion in obesity-related healthcare costs by 2030. The costs of obesity, of course, are also in terms of physical costs. As a family doctor practicing for 20 years in California, I saw the devastating effects of obesity, which causes heart disease, stroke, high blood pressure, diabetes, cancers, high cholesterol, high triglycerides, sleep apnea. A number of diseases are attributable to obesity.
Doctor, if you could go back to your last slide, just one quick question. The last bullet, if adult BMI was reduced by 5%, we could save $81.7 billion. That footnote, number 6,
yes.
What is that footnote?
So I have footnotes throughout the slides. It's referencing certain articles and publications. In this particular case, this was Trust for America's Health Foundation through Robert Wood Johnson. The article or the literature is called F, as in fat, How Obesity Threats America's Future. It was from 2012.
Okay, I guess I have to read it. I was curious about if you knew what the methodology was and how it.
Yeah, the methodology is in the report.
Right there. Okay.
Sure. So I do want to get into strategic priorities to prevent obesity and chronic disease, increase access to and consumption of healthy foods and drink, and of course decrease access to and consumption of less healthy foods and drinks, increase opportunities for safe physical activity through healthy communication and transportation design, and decrease sedentary behavior. The obesity factors, protective, include breastfeeding, dietary practices such as increased fruit and vegetable consumption and regular physical activity, and of course the risk factors are dietary practices such as intake of sugar-sweetened beverages and high-calorie, low-nutrient foods. Screen time is an independent risk factor for obesity and sedentary behavior. And we know that poor eating and exercise patterns are often established during childhood. Therefore, parents have a profound influence on childhood obesity by providing a healthy home environment, being involved in supportive and role modeling healthy eating and physical activity. Ready access to healthy and supportive environments where people live, learn, work, and play promotes healthy eating and active living. We know that sugar-sweetened beverages are a major risk factor for obesity. As Dr. Crawford has mentioned, nearly half of the added sugars consumed by Americans come from sugar-sweetened beverages. And we know that children and adolescents who consume more sugar-sweetened beverages have higher body weight compared to those who drink less, and there's evidence as well to support that relationship in adults. We have the Let's Get Healthy California work, task force created through the governor's executive order with the vision for California to be the healthiest state in the nation over the next 10 years. We're tracking a number of indicators, including sugar-sweetened beverages, the proportion of adolescents who drank 2 or more glasses of soda or other sugary drinks per day. The California baseline in 2009 California Health Interview Survey was 27%. You can see the California update from the 2011 interview survey. It actually went up to 30%. And our California target over the next decade is 17%. That was established through the Let's Get Healthy California task force, of which Senator Monning was a participant. Thank you. There's strong evidence that indicates that regular physical activity helps people maintain healthy weight and prevent excess weight gain. You can see the percent or proportion of Californians who get the recommended amount of physical activity, not very high. And within the realm of active transport and obesity, we know that walking, bicycling, public transport use contributes to daily physical activity, aerobic fitness, cardiovascular health, and helps protect and prevent obesity, diabetes, and other diseases. Unfortunately, active transportation has decreased in California and the United States, and we know that each additional hour per day spent in a car is associated with a 6% increase in the likelihood of obesity. It's important to design communities to safely accommodate pedestrians, bicyclists, and public transit users, as well as vehicles. We call these complete streets. We have our Safe Routes to School program in collaboration with the federal government, and we partner with transportation and traffic safety agencies, such as on the California Transportation Plan 2040 and the Public Transit Plan. It's important to note that perceived safety of the neighborhood environment is an important factor in physical activity. If the neighborhood is perceived as unsafe, children are less likely to play outside, and adults are more wary about walking or taking part in physical activities. In Let's Get Healthy, we are tracking the indicator which was mentioned by Dr. Crawford, the fitnessgram, and the task force set a target for 36% for 5th graders, 46% for 7th, and 52% or half of 9th graders. We have a long way to go to meet that target. We know that living closer to healthy food retail is associated with decreased risk for obesity and other diet-related diseases. There are 2.2 farmers markets per 100,000 residents in California. This is less than the national average of 2.5. And nearly 1/3 of adults in California report having limited access to quality, affordable, and fresh fruits and vegetables in their neighborhood. Those living near an abundance of fast food restaurants and convenience stores have a significantly higher prevalence of obesity and diabetes. Fast food restaurants are often located near schools, and we know that that proximity has been linked to increased risk of obesity in school children. In 2005, there were 4 times as many fast food restaurants and convenience stores in California than supermarkets and produce vendors. And we're tracking the consumption of fruits and vegetables in adolescents and adults through Let's Get Healthy California. And you can see the California target for a proportion of adults who have consumed fruits and vegetables 5 or more times per day is 34%. Finally, I just want to mention some of the activities that are available to prevent obesity and assist folks who are overweight and obese. I think it's important to increase the referrals to such programs as Walk with Ease from the Arthritis Foundation, the use of the Chronic Disease Self-Management Program developed by Stanford School of Medicine, the Diabetes Self-Management Education through the American Diabetes Association, and Wise Woman, which is funded through our department through the Center for Disease Control. We have a number of activities in our department, not the least of which is the WIC program. Several years ago, WIC changed the food package, and now moms have healthier choices. We have our California Wellness Plan in the department, which has 4 strategic areas: healthy communities, optimal health system linked with community preventive services, accessible and usable health information, and prevention, sustainability, and capacity. This is work all geared towards preventing chronic diseases. And in fact, tomorrow we roll out and kick off the California Wellness Plan with a 2-day conference called Advancing Prevention in the 21st Century. The department and the funding through the CDC has supported invitations to hundreds of people, and there will be a showcasing of best practices here in Sacramento, and a number of partners from all over the state will be attending, where we'll be obtaining commitments to contribute resources to achieving our goals with that plan. We also have a California Obesity Prevention Plan, which provides guidance in the department for our obesity prevention work. And lastly, we have our Nutrition Education Obesity Prevention branch, where our SNAP Ed dollars are located and CDC dollars. This branch provides breastfeeding trainings, local school wellness support, and has a number of resources available, including toolkits, case studies, and our Children's Power Play campaign. Thank you very much.
Thank you. Any question from any of the members? Just a follow-up on dealing with healthy communities, and obviously, dealing with bike paths, roads, safe roads. What are some other thoughts and ideas that you've looked at that'll help promote that?
So the whole concept of community design, the concept of the built environment actually encouraging physical activity is relatively new to public health. I actually had my first meeting with a county planner about 8 years ago, and he was very confused why the county public health officer was coming to meet with him. I actually talked to him about safe routes to schools, and he was very familiar with that program, thought it was all about preventing injuries in children. And I said, no, it's about preventing childhood obesity. It's about creating streets and neighborhoods that provide safe access to schools so that children are no longer driven to school, that they're biking, walking, skating, and that turned the light bulb on. You could see him brighten up to think that his work was actually engaged and involved with preventing childhood obesity. So one of the major aspects of this is public health collaborating and partnering with Caltrans through our Health and All Policies Task Force, for example, at the local level with county and city planners, because those are the folks that are designing communities, and it's just really recently that we've engaged with them so they understand the health implications of their decisions. At the state level, the Office of Planning and Research to the Governor's Office is presently creating the general plan revisions for the state, and there are going to be health focuses, public health implications written into that plan, for example.
Okay, thank you very much. I appreciate the presentation. We're going to move on to the next presenter, Dr. Bindra, Chief Medical Officer, Citrus Valley Health Partners.
Good afternoon. I'm Pavel Bindra. Hello, Senator. Nice to see you. I'm the Chief Medical Officer and the Chief Information Officer for Citrus Valley Health Partners, which is a 600-plus bed health system in East LA County. We are responsible for taking care of almost 1 million folks in the area and are quite used to having to grapple with the issues of obesity. A lot of the information, the background perspectives have been covered, so I will skim over that. I plan to just provide some perspectives around obesity, some of the medical issues and treatments around it, and then actually focus a little bit on how it affects the business of delivering care in hospitals, and as the Patient Protection Act comes into bear, start talking about how hospitals are taking on their social contract with society and delivering on the message of actually preventing obesity and actually investing on the front end and the taking away of obesity and preventing some of the complications that we see. And subsequently talk about the implications for the human resources, which is a strong aspect of obesity as well, and then some of the work that we're doing in the community. Simply put, obesity is basically the ratio of your weight divided by the square of your height in meters, and so the cutoff is 30, and as has been covered before me, it's responsible for almost 5 to 10% of the total health expenditure in the United States. The U.S. prevalence of obesity and overweight folks is over 30% now, and by some estimates, depending upon where you look, including the production losses, it accounts for greater than 1% of the gross domestic product. And determinants includes lifestyle commodities. Sugar beverages have been covered in great detail over here. Government policies, the greening of our cities is a very important issue. transportation and urban planning, and urban planning does have a big role in this, and changing work conditions. I would say that while Twitter and Facebook have helped us become a connected world, it's also helped us become a fat world. And the changing work conditions and the computerization of the workforce is certainly adding to that. This just, it's a busy slide, but it just shows that mostly the developed countries provide more than their weighted average to the overweight trend in the world. And the United States certainly over the last 20 years has been getting heavier and heavier. On the left-hand side, you have the male statistics. On the right-hand side, you have the female statistics as shown in 2008. And the trends are increasing. The California obesity rate is around 24% right now. Not as bad as several other states, but certainly it's in the top 10, in the bottom 10, but not the best. Comorbidities include several, which are diabetes, as Senator Monning pointed out, with the onset diabetes, that now no longer is relevant since even kids are having diabetes at a young age. Coronary artery disease, hypertension, lipid disorders. As folks get heavier, they get heavier on the neck, they start having sleep apnea, and you're going to start seeing a lot of the Charles Dickensian era of the Pickwickian syndrome. As folks get more and more obese and are not getting the right sleep, they're going to look more and more fatigued, and the classic blue bloaters, which is what the Pickwickian syndrome is all about. And then musculoskeletal disorders, including osteoarthritis, because of the amount of weight that those knees have to carry. Bottom line is the treatment is negative energy balance. On average, in the US, we are ingesting more than 300 calories more than we were a decade ago. And add that up every day over a year, and you get the picture. We are high up there. What's needed is a low-calorie diet and physical activity, which is more than 250 minutes a week, which basically comes to around 6 hours a week, almost an hour a day. Behavior modification we talked about, and then pharmacotherapy, which I think is going to be covered after I'm done presenting as well. Certainly bariatric surgeries, which have shown a lot of good results with sustainable weight loss. But I would add over here that what we save by not providing good prevention for overweight folks, we pay after the fact with surgeries which can sometimes get botched up, or which is a natural consequence of any procedure in medicine with complications and ulcers and bleeding and death. And I would say that the return on investment upfront would be significant, and maybe there will be a day when bariatric surgery will become a relic of the past. But certainly, for now at least, it does help with the sustainable weight loss. I want to spend some time on the economic imperatives around obesity. It certainly is making its presence felt in the hospital world. We now, as a hospital system, have to invest in wider wheelchairs, which can cost 2 times the average wheelchair. But when you look at that a little further, that does mean that we have to start breaking down doors in the hospital to allow these chairs to come in. And that in itself adds a lot to the cost of the hospitals. Heavy-duty stretchers, beds, which can be 3 times more expensive, larger blood pressure cuffs, bigger beds with higher weight capacity, larger CT scanners. I certainly have had patients who we've had to hold off on a CAT scan, which could have been a very important thing to do because we can't find an open scanner anywhere, or the health plan will not allow the patient to go somewhere to get a scan for that, or the quality of the study can be so diminished that it's almost worthless to get that study done. And so we do have apparent and inapparent costs to obesity, and certainly ambulances with reinforced stretchers and winches. I just put some dollar figures, not from my hospital, but from a hospital in California, in New York, just to show you the average cost. And it's when you add that over several million patients, several thousand hospitals across the country, and especially in the state, it does add up significantly. So when we're treating patients of size, we have to remember that the hospital industry is a very labor-intensive industry, and there's a lot of manual movement of patients by staff which is needed. And certainly a game changer for us has been the use of lift equipment, because before that, thrown off backs spine surgeries and the workforce, workers' compensation requirements were starting to head upstairs. As I mentioned, we've had to delay or adjust treatment plans for patients. Certainly, there's an increased risk to moving patients. We've all heard of patients who have fallen down in the hospital under our watch, which is a shame any day. But certainly, with an obese patient with the reduced ability to heal from harm, that can be catastrophic. And you name it, there's a cost to everything: bedsides, commodes, overhead rails to transfer patients. That's a requirement. In my own hospital system, which Senator Hernandez is very familiar with, we have 30 to 40% of the patients at Citrus Valley will present with a BMI, which is more than 30. Last year, we did an analysis of our patients with respect to the effect it has on the hospital personnel, and we saw that 85% of the time there are patients between 400 to 500 pounds in the hospital, and 46% of the time there are patients who are greater than 500 pounds of weight. I've had to round on a patient who was 680 pounds. She ultimately died, but it was not a dignified death. I want to spend some time on scope of worker injuries. I mentioned the liability of moving patients and related physical activity resulting in injuries in my workforce. Certainly increased patient falls, injuries to my hospital employees, workers' compensation claims, which are not insignificant, as we all know, lost time from work, that all adds up. And oftentimes in our workers, these injuries can be pretty bad. When you imagine when you're trying to lift up a 500-pound individual in the land of Lilliput, even, that would be dangerous. And as I'd mentioned, the P is missing over there, but that would be the Patient Protection Affordable Care Act. It does empower employers to battle obesity, and certainly there can be philosophical discussions around this issue about the social contract and the state's role in this, but certainly employers are now slowly, especially as they're becoming self-funded, doing some work around incentivizing patients to do wellness programs. And as some of you may know, some of the employers now, with the mobile apps that are available, we are able to keep track if the workers want to do so, figuring out how many steps they're taking a day and actually tiering it and giving them some incentives with premium cuts. And you're going to be seeing that a lot in hospitals as well. With respect to injury prevention programs, as you know, the California's Hospital Patient and Healthcare Worker Injury Protection Act requires us, the hospitals, to develop and maintain a safe patient handling policy and periodically and methodically assess the equipment needs to make sure that we have equipment such as portable lifts, overhead lifts, and transfer sheets, which really is the right thing to do because the cost up front certainly helps minimize costs later on with preventable injuries, and conduct data analysis and respond accordingly, which I'm happy to see is escalating at the highest levels in the state as well, and certainly conduct training for employees to work in a safe environment. I just want to take a couple of minutes around what hospitals are now starting to do. As we transition from volume-based care, where the idea was to just do more of the same, to value-based care, I can honestly say that society as a whole is allowing all of us to celebrate the empty bed. And the act, and especially the legislation in California, aligns all the interests of all the stakeholders in a way that we can do this. So, for example, in my hospital, we have something called the Lighten Up San Gabriel Valley program, where we have weigh-ins, we do walks together in the city, and we are tracking these folks who are joining us in these missions and community runs, and actually then making a big deal about measuring the waist size of individuals and celebrating it when they have done that. With that, I'll conclude my presentation. Thank you for the opportunity to come here to present, and I'll be happy to take questions.
Thank you. Any questions for any of the members? Senator Mani?
Thank you. Thank you for being here today and for sharing kind of this perspective from hospital-based community. The metrics you shared on increased costs for equipment, I know of a clinic in Monterey County that also had to replace its scales because they only went up to 300 pounds and they had to bring in livestock weighing scales to be able to get accurate weight readings on patients. So it's indicative of a big problem.
I couldn't agree with you more, Senator. I had a situation where I'm an electrophysiologist, and I had to do an ablation on a patient, and the table could only honestly take up to 350 pounds, and I had to do an AFib ablation, so I had to puncture it through the top part of the heart to go in, and it's really not good if the table moves as I'm about to move the needle. So I had to wait for several months to let him get his weight down to do that. But the point I would like to make over there is that we thought that a table which could handle 350 pounds would be enough. But within one generation, we've seen that even that's not enough. I didn't know about the livestock, but with your permission, I would like to share that when I'm back in LA. Great.
Thank you very much. I appreciate the presentation. And
Thank
we'll
you.
move on to the next one. It's item number 4, clinical approaches to address obesity. Dr. Fujioka, Director for the Center of Weight Management and Director of the Nutrition and Metabolic Research and Scripps Clinical Research. Welcome.